at various times. But welcome everyone to this month's Innovation Club, which is around enhancing patient experience using virtual reality, current practice and future opportunities. And I suppose that gives us a nod to today's agenda, which I think everyone can see on screen, or I will put on screen. Could I just show the agenda on screen?
In the other room.
Oh.
You are screen sharing.
So could I just have a nod? Tom, can you see the agenda on screen? Or
I can see you're sharing your whole screen, Richard. Now I can see the agenda.
That's perfect. Thank you very much, Tom. Thank you. So, as I was saying, that gives a nod to today's agenda, which is really an opportunity to share some of the current use cases of virtual reality that is already being implemented across Leeds Teaching Hospitals Trust in a variety of different settings. So we'll be hearing from Lisa Beaumont from Leeds Children's Hospital, Rachel Davis from the Learning Disabilities and Autism team, and Barry Morgan-Davis from Stroll and the work that they're doing on neuro rehabilitation. And then a look ahead really to new opportunities and new use cases. And of course, a prime reason that we're here today is that there is a new opportunity through Leeds Hospital Charity. So you'll be hearing at the end of today's session from Charlotte Self around that new funding opportunity that is now already open and live. So Charlotte will tell us more about that. But really interestingly, the opportunity to hear about some use cases from some other organisations and some other companies. So we have Alex in the room here from Reprio VR. So you'll be hearing from Alex about using virtual reality for dementia care. You'll also be hearing from Tom Carlisle, who is a Digital Innovation Fellow at Chelsea and Westminster Hospital, on how they're currently applying virtual reality and some of their future direction in that space as well. And unfortunately, we don't have Liz Green from Leeds Dental Hospital with us today, but I'm sure perhaps we'll get another opportunity to see how they're using it in the future. So I think without further rambling from me, I'm just going to hand over at this point, I think, to Lisa, first of all, to present. So thank you for joining us, Lisa. And Robert's going to change on screen. Thank you.
Thanks so much. So, yeah, so you can see what I'm talking about. So, good afternoon, everybody. Hopefully, everybody can. Am I standing in the right spot? Everyone can hear me. As I was introduced, my name's Lisa, and I'm very lucky to be the Therapeutic and Specialist Play Manager here at the wonderful Children's Hospital. I'm here to talk about the VR that we've done in Children's, where we started, where we're going, and who knows where we're going to end. So exciting times. So basically, we started looking at our VR within Children's because the consultant was big into gaming and using VR. And he approached, obviously, the health play specialist and said, I've got this idea, do you think you can help me? And we were like, yes. So we set up a task force, which was great. And then we had to do some of that research, which really for a health play specialist is something completely out of our comfort zone. And we had to do lots of research. Unfortunately, we got supported by Starlight, who are a children's charity, and really championed, and with their research and doctors and innovation team, they helped us produce a really fantastic research and evidence report that shows that, you know, using VR in children lessens their anxiety in a whole range of procedures, from cannulations to blood, lumbar punctures. We went to theatre, took somebody's toenails off. Lots and lots of research, but we found when we got this research that we needed some time, obviously, to invest in that, and we needed, obviously, a person to be able to deliver and lead on this role, because gets lost in within the business of everyone's role. So we were very fortunate after this 6 months of setting up and doing this research project. The wonderful Leeds Hospital Charities sponsored a wonderful health play specialist called Lucy for 2 years to really lead and champion the VR at the Children's Hospital. So we started getting our things together, getting our jigsaw pieces together, and really pulling everything together in terms of where we needed to start. As I said, we collected lots of data from using our VR, and obviously used that in creating a wonderful report, which you can find on the Starlight website. And it took a lot of time and effort to do that, but it was greatly received. And then we started up a referral process where we were able to refer patients in to have a procedure using VR. And the whole sort of, way I sold this to our TRI team and our sort of, consultants, etc., is that, there were opportunities where we could avoid having general anaesthetics with some of our children for a whole range of procedures. And at the end of the day, this really fed into our patient experience journey. So what we did with our research is we made sure that within our sort of areas that everyone was trained and competent in using the VR. Between 2023 and 2024, we did 350 patient reactions. We had a referral system where you could refer in, obviously, for your patient to be seen and assessed and use the VR kit. And we did all sorts of procedures from cannulas, blunt tests, lumbar punctures, etc., etc. Obviously, the feedback was amazing. Many patients reported feelings in confidence and relaxation. And, we had some interesting discussions and interesting experience from people that were referred, everything from a child who may have had to have a dressing change because their hand had half disappeared from a firework injury. Well, obviously, using VR, we were able to make that a more positive experience. Internal examinations, which can be really difficult for, obviously, a lot of young children. So we've used it in so many, I could talk about the experiences all the time, but we have used it in so many positive patient experiences. Then we went on when we implemented and embedded this within, obviously, the General Children's Hospital. We went on to support the oncology department, and we worked with the oncology department on regular meetings and handovers, creating pathways and questionnaires to ensure we had the right patient caseload. And Lucy introduced herself to staff and parents, and we completed workshops to promote this to our parents, because being able to get a parent to think about using this when actually they have a general anaesthetic was a huge task. Well, they're fine having a general anaesthetic, but actually for some patients, it was an easy win, and for some patients it wasn't. So we gathered lots of feedback, and we did lots of work with a few families, and then shared these case studies with our children and families within oncology. So here you can see I've got a patient having a lumbar puncture using the VR. And we've trialled this in some VR workshop, and we've also accessed some post access. And we've also used it with some children who have a bad experience with having a general, anaesthetic. And I've had some interesting conversations with consultants. A couple said, I want to use VR with a 6-year-old, and it's too young. It's not going to work. Yeah, well, we want to do a PICC line. But, well, we're disagreeing with you. Well, the risk for this child to have a general anaesthetic is too high. So we want to try that procedure. So, we've learned some lessons that actually you can do it with a 6-year-old. And, the doctor was right in that instance. So, we've been open and flexible in trying it on different approaches of age and conditions, etc. So here you can see that one of our patients, when he got confident with VR, is having a lumbar puncture, and has now had 2 successful lumbar punctures with VR and local anaesthetic, which, is a great achievement within itself. So, the feedback when it was time for the lumbar puncture, I went into theatre, sat on the bed, put on the VR headset and leaned forward. I watched the first of the videos we had chosen the week before. I could feel the doctor pushing on my back a bit, but because I was watching the video, I didn't pay any attention. Before I knew it, I was done and being told to lie down. Usually when I wake up from general anaesthetic, I feel really groggy and sick, but this time I felt great. I was then taken into recovery, had to lie down for an hour, but after that was over, we were allowed to leave, and I felt fine the rest of the day. I really recommend it. I think it's a great way to, rather than having a general anaesthetic. So for me, it's always about the patients and sharing their stories, in terms of, you know, what a difference the VR can make. Another young lady, as you can see here, a cystic fibrosis patient, needed a 2-week course of IVs and a PICC line insertion. Always had a general anaesthetic in the past, trialled VR and agreed to use it, and successfully completed the procedure with VR and local anaesthetic. So, you know, again, no need to have a general anaesthetic. And let's be honest, who wants to give a general anaesthetic when you don't have to? So some really good and positive, and I could speak about these all day, but just a couple of examples. And again, feedbacks from our patients. It's very good and very distracting, reducing my stress and anxiety around my procedure. It also has relieved the boredom while I've been in hospital. I think my hospital experience would be hard, and I wouldn't have had my procedure completed without the VR headset, because I would have to look at what the doctors were doing. So, you know, I think, you know, the patients are, you know, the selling point in using RVR for me. So how is the project funded? Leeds Hospital Charity funded our VR play specialist for 2 years and also fund some of our kits. We did start off with one kit, which was sponsored by Starlight, and we've now got Starlight funding 2 of our Rescape headsets, and we've got Leeds Hospital Charity funding some, and they did fund our virtual reality play specialist for 2 years. What Lucy has done over that 2 years is upskilled all our play specialists in all our areas, because they know the children best. And so my team now have the skill set to be able to use VR, whether you're in outpatients, ward 49, 51, and we've got 6 headsets now across the Children's Hospital that are in constant use. I've had to drag that away this afternoon, and Richard often has to do the same, always borrowing it. So yeah, they are used tremendously, and a lot, and we wouldn't have them. They're not cheap, but you know, we have tried a few different headsets. Don't ask me to name them because I can't remember. But you know, the children have voted, and obviously we've done feedback with our children and our staff and our parents, and this is, you know, the one that works best for us currently. So just some top tips for using the VR, which is, you know, great to go away with. Obviously, you know, about keeping still, you've got to do the preparation. You don't just stick the headset on the child and say, right, here we go. So before the doctor comes into the room, there's lots of preparation, regulating, getting ready, you know, preparing them still for the procedure, so they've got an absolute total understanding of what's happening. So we've got some noise cancelling headphones, because, you know, they work well sometimes. There are some side effects, you know, from using the VR. Sometimes, you know, children can feel a little bit nauseous and things like that, and it's not for everybody. Some children like to look. It doesn't matter what you're doing, how grim it is, they want to have a really good look. And sometimes the parents say, can I put it on, because I don't want to. So it can be, you know, really interesting. But, you know, people would worry about doing a lumbar puncture, but if you prepare the child well, you know, they do keep still, they know the importance, you know, of using the VR, and, you know, it is taken really, you know, seriously as a spotted piece of preparation for procedures. So looking into the future, we're working closely with Healthy Minds and BJON to support patients having this new senescent treatment via lumbar puncture. So I can't talk too much about that because Lucy's leading on that project and she can't be here at the moment. But in a nutshell, it's a piece of research where they're using VR for this specific procedure, and obviously looking at the findings of using VR within this procedure. So it's in the early stages, but, you know, who knows where that's going to go to and where the next steps will go with that. We continue to collect data and feedback from our patients because, you know, that's the kind of thing, I'm sure Charlotte would agree, that, you know, Leeds Hospital Charity want to hear about, you know, that makes a difference. I could talk about it making a difference, but I think when the charity hear it from the patients, that what makes a difference. you know, we're happy to continue to trial new VR sets to improve patient experience. And I'm sure, you know, technology has changed and things have moved on, but there's always seems to be a cost implication, you know, to the VR. And obviously, as you know, we have very limited budget within the NHS. So again, that's all dependent on funding from Leeds Hospital Charity. And as I said, train all our place staff to reach a higher patient, you know, caseload. And ideally, in an ideal world, you know, my sort of, you know, vision and where I would like to be is offering VR as a part of children's treatment as they arrive. But, you know, I think in terms, if I was to promote this, I know my colleague Rachel would know, we wouldn't do anything else apart from VR. Because, you know, why wouldn't you want to use VR if you're coming into hospital with a sick child for a dreadful treatment? So that's where we currently are. Many thanks for listening. Any questions? That's just a whistle top shirt. I won't. Over to you.
Brilliant. No, thank you very much, Lisa. Thank you. So any questions from anyone in the room, and perhaps also questions from anyone online?
What's on the VR?
So we've got all different things. There's some gaming on there. There's some relaxation. So gaming and relaxation are the main things. We're going to stay around so you can come and have a try. The gaming is quite popular because, you know, some of the children are into games and they come regularly. So, you know, we might have a game leaderboard. They want to be top of, you know, they're like, do as many procedures you want till I get to the top score here. And things like that. So there's a whole, you know, range of, you know, procedures and things, but, you know, you're welcome to come and, you know, have a little play, you know, it's great.
Thank you very much, Lisa.
Is that
Round
okay?
of applause. Thank you very much. And I think I'll go straight on to introduce our next speaker, if that is okay. So next up we have Rachel Davis, who is now lead professional for the Learning Disabilities and Autism team, and she's going to talk about the use of VR in your service.
Thank you very much. Hello everybody, so as Richard said, I'm Rachel. I'm the lead professional for learning disability. So I work within the learning disability and autism team in the trust. So that's a lifespan service supporting children, adults, everything in between, inpatients, outpatients, every speciality within the organisation we support. So I think this is right at the end. There we go. We won't do it backwards. There we go. So I wanted to talk to you a little bit about why we kind of looked at the use of VR within our service, and I want to give you a little bit of background about our patient group and our team as well. So VR's been kind of increasingly used to support people with a learning disability within education settings, therapy settings, healthcare, life skills and social development. The team's been using VR now for around 2 years, following some financial support from the charity, which we're ever grateful of. I guess similar to what Lisa said, we've tried it with a lot of different patient groups, and we're probably a little bit further behind than the play teams, as we've not yet finalised all of our research, but have used it with a broad range of our patients, which I will tell you a little bit about earlier. So the scope of our service currently, so in 2023, 2024, adults with a learning disability occupied 14,169 bed days in the organisation. There was a total of 4,814 outpatient appointments for patients, adults with a learning disability. Similarly, within children's, we had 8,900 bed days, children with a learning disability and or autism, and 4,702 outpatient appointments, which really tells you kind of the magnitude of the patient cohort that we're supporting. And in terms of clinical support, we're currently a clinical team of 5. So that has grown astronomically from a team of 1 8 years ago. So there is progress. So why did we think of VR? We wanted to look at alternative ways to become more trauma informed, and our patient group faces such significant health inequalities. We needed to think about new creative ways to support that patient group. And the use of technology had been discussed in a couple of forums that we were in, and thought this would be a really great opportunity. A lot of our patients experience really high levels of anxiety, stress and pain around hospital. Just mentioning the word hospital can be really quite triggering for our patients. And we found that a lot of our patients were their well-being significantly reduced when coming into hospital. We have a wonderful reference group made up of experts with lived experience. So we took it to our experts who help us form everything that we do and said, what do you think? It's a good idea, bad idea? And they were really on board with it. So we went ahead. We spoke with the Children's Hospital and looked at what they'd been doing and wanted to build on that work, specifically within our adult population. One of the key drivers behind our use of VR was Stomp and Stamp. So Stomp and Stamp are guidelines and initiatives set out by NHS England, which addresses the use of medication in our patient groups. So the majority of our patients, when coming into hospital, are often prescribed a sedative, things like lorazepam, promethazine, before they even come to hospital to help them get through procedures. And across learning disability and autism population, there's a real move to kind of reduce this over-reliance on medication and look at other ways of moving forward with care. So we thought about Stomp and Stamp, thought, how amazing would it be if we could have a VR headset instead of promethazine, lorazepam, midazolam. As we've said, people with learning disability and autism often face real significant challenges with regards to accessing their healthcare, especially those that have chronic conditions such as kidney disease. Lots of appointments, lots of blood tests, lots of prodding and poking, and they just get really fed up of it. And all it takes is one person really on in their journey to give them a really negative experience, and every single hospital attendance they're on is really traumatic. So we're really keen to kind of get in early with our patients and show them how accessible the hospital can be. And then I've got a statistic on the end, which is a great statistic at highlighting why this work is needed, but quite a sad statistic as well. So 42% of deaths of people with a learning disability are avoidable, with a median life expectancy of 62.9 years versus 82.6 in the general population. So it's these statistics that drive services like ours being commissioned. This patient group does not have equitable access to healthcare yet, despite really significant advances in the field. So we need to keep pushing forward with new and innovative ways, such as the VR. And then just a little bit about the Equality Act. So the Equality Act outlines that we have to put in place reasonable adjustments to ensure patients with a learning disability and autistic patients have equitable access to healthcare. That's not equal access to healthcare, it's equitable, and the difference is really important. So considering things like the use of VR to support our patient group is one of those innovations, to look at overcoming anxiety and fears about interventions. Been utilised by the children's team, which is wonderful, to successfully help during minor surgical procedures, like Lisa's explained, and we've continued to try and push that forward within our adult provision also. One of the difficulties that we found within the adult provision is that quite often a lot of the trauma has already occurred. So building trust is really, really crucial, and making sure that we have a named member of staff from our team to build up that rapport and help build up the confidence to a point where we can use the kit with them. So Callum. So I'll tell you about Callum. Callum's 19, he's autistic, he's got a learning disability and kidney problems requiring blood tests. He lives with his dad. His mum sadly passed away a couple of years ago, and since then he's found hospital even more increasingly difficult. He's got a really supportive family who are trying their absolute best to get Callum to access hospital. Callum's special interests are the Titanic disaster and the solar system. So from straight off from the off, we get things that we could talk to him about, chat about, and try and understand what drives Callum, what makes Callum happy. His needle phobia stemmed back from one experience when he was 10. And from then on, every hospital attendance, every blood test has been really traumatic. They've used chemical restraint and physical restraint to get bloods from Callum. So Callum and VR. So we looked at desensitisation with Callum. We've practiced the steps involving a blood test. As Lisa said, you can't just go straight in with the VR and then take someone's blood. There has to be some preparation work. So we got Callum used to the environment and the equipment, how it felt to have a tourniquet on, how the cream felt on his hands. We used a biro pen tip and a spiky sensory bolt, you know, the ones where you bang them and they flash. Spikes on in the grate. On Callum's arm to get him used to the sensation of someone touching his arm and quite a sharp feeling on his arm as well. Showed him the butterfly needle in the packet so that he could see the size and see the shape and see what would be happening. We arranged for the blood test to be done at the hospital in a separate clinic room away from the main phlebotomy room because it can be quite loud up there. And for Callum to have some time to settle in and get relaxed. He was able to successfully tolerate the blood test while watching the video on the VR headset. He was aware of what was happening, he was engaged in what was happening, and it went really well. So that's Callum. Wonderful outcome for Callum, who now doesn't need any sort of medication or physical restraints, have routine blood monitoring. And then a little bit about Derek. So if anyone's heard our team talk about VR before, Derek is our poster boy for VR, and he's very proud of that. So Derek is a high volume service user, so he's coming into contact with health quite frequently. He's got real significant health anxiety. He care seeks, so thinks of reasons to come to hospital to kind of get professionals to look after him, make him feel assured and build that trust. But he's also really mistrusting of services, so feels that people don't listen to him, feels that people let him down, and it's a really hard balance for Derek and accessing healthcare. Every 12 weeks, Derek was on the elective surgical pathway for I always struggle to say this, suprapubic catheter change. So that meant that every 12 weeks he required an admission, sometimes for 2 nights, where he would have a general anaesthetic and a catheter change under that general anaesthetic. And the cost for each suprapubic catheter change was over £2,000 to the organisation. And it's just at the bottom, it says there that doesn't include any frequent ED attendances where he's had problems with it, GP appointments, extra clinic appointments. So then what you can see on the side here is a little insert from Derek's health passport saying how he hates the delays for the waiting lists. He doesn't like operations, doesn't understand why things are delayed, thinks people aren't helpful and thinks they're not helpful on purpose. He needs to be told clearly what's happening and making sure that we tell his support workers what we're doing so they can help him understand the information. So that was Derek pre-VR. So, benefits to the use of VR for Derek. He had a better experience of healthcare, feeling positive and proud of utilising the VR. He re-established trust to support engagement with professionals. He reduced the amount of general anaesthetics. It was 8 nights stay in LTHT per year for Derek that were avoided. At least 4 theatre slots per year were avoided. We reduced the significant health inequality. We aligned with Stomp and Stamp, which we mentioned earlier. And the cost saving for Derek alone was over just shy of £8,000 per year for the trust. So this is Derek. So you can see that Derek there with his VR headset on with Alison Conyers, who was the lead professional, and some of the wonderful clinic staff over in urology. So Derek now accesses a nurse-led outpatient clinic for his catheter changes. He has diazepam prescribed by his GP, a much smaller dose that he has on his way into hospital, and he's a little bit calmer when he gets here. He attends with a preferred support worker. So that was Alison. We've had a bit of a transition over to a new member of staff recently after Alison had left. And he continues to access the clinic and use the VR headset, which brings Derek's suprapubic catheter change to a grand total of £411 versus the nearly £3,000. So here's some data. So we've got the same kit as Lisa, which is great because I didn't bring mine. So here's the kit that we use. Ours is out this afternoon, unfortunately. We've not got 6. So the kit actually, it comes with a portal where when someone uses the piece of kit, you log kind of pre and post procedure, how anxious they're feeling, what their pain levels are like. So here's some of the findings off of our from our patient group. What I will caveat this with is some of our patients aren't very reliable at reporting pain accurately, and the pain scale uses words like pain-free, very mild, discomforting. Not great for our patient group. So we're looking at translating this into an easy read version and looking at scales that have got numbers, scales that have got pictures of faces, so faces that are really happy or faces that are grimace because they're in pain, to make this more accessible for our patient group. So this data here demonstrates that with 41 different individuals, there was on average a 36.8% reduction in pain. And this one for the same set of individuals says that there was a 60.3% reduction in anxiety. So next steps and challenges. So our team needs to formalise our findings from the use of VR and produce a wonderful report like Lisa's report to really evidence how beneficial it is and pull the really clear data on that. We need to increase the scope of VR to wider than procedural anxiety. We want to concentrate short sessions of VR in high stress areas such as HDU and ICU, especially thinking about our patient groups that might be coming round following lengthy stays on ICU, how we can help them kind of settle and find some peace and some calm within that environment that are often really daunting for our patients. We know that this work saves the organisation money and targets health inequality at the same time. And we want this to become more core business for LTHT. So rather than VR being the exception and an innovative idea within a few different specialties, we'd love to see this being kind of more broadly used across the organisation. So we have had previous charitable funds that have helped us with our VR kit, and this year's VR funding has come directly from our budget itself. And we're keen to draw up that research project and take that through our local governance and see if there's a way that LTHT can take those costs on in the future. We want to work with other teams and the innovation team to progress this work, and are currently working with the tissue viability team to see if there is scope of sharing our kit across the two teams and creating a research piece around wound care as well. So looking at the patient groups. I think from me, any questions?
Thank you very much, Rachel. Fantastic presentation. Barry's got a question.
Yeah, again, yeah, a great presentation. Out of interest, are you doing or will you be doing any sort of desensitization sort of therapies? Like, so does the patient need to have the VR kit long term? Do you know what I mean?
So the longer term cases that we do, they come into hospital and use VR within the hospital for a set amount of time. So we've got a patient at the minute who really struggles to just get through the front door. So we've gone out to the car outside one of the theatres and we've sat with the VR in the car. And the transition into that person coming into the building, and the end goal with that is that at their final appointment they will have the procedure done. So we use it longer term with specific patients. Yeah.
Have you had any patients that don't need it long term after doing it to get over that sort of initial anxiety?
I don't think we've got to the final stage with the longer term one at the minute. We have some patients that have used it numerous times and then come in and not needed it 2 or 3 times in. But the longer term ones, a lot of our patients take 6 to 9 months to transition into the hospital. So we've not got that far yet, but it'd be really good to see if they can then come in and not use it.
Yeah, I think that's a really good question. What we've been looking at some children, like you say, do they actually need the VR now? Because, you know, it is a great sort of, you know, resource to have, but, you know, we've not got capacity. So, you know, we've been talking about, do we offer 6 sessions and then review and evaluate? Because, you know, if you're offered it and Jimmy's loving it, why wouldn't you have it? But we haven't got that capacity. So that's something we're currently talking about, you know, giving a set amount of sessions and then review it.
I think that's one of the things that we were really keen on in terms of the financial side of things as well. So often with our patient group, once you set a precedent, that's what happens when they come to hospital. So Derek comes to hospital and he has VR, and that's the rule now. So that's kind of why we're really conscious of the finances of the VR. So if in 3 years' time, for whatever reason, we don't have any ongoing funding for VR, we've got a whole cohort of patients now who previously didn't access hospital and without the VR now won't. So how do we maintain that or protect that moving forward is something that I can do about later. Me too.
And the clear articulation of the benefits and actually the cost savings seem like there's an immediate data a case for it to be made more business as usual.
Yeah, and Derek's case alone funds it for over a year.
Yeah.
So, it's pretty clear cut.
Great to hear that potential kind of working with tissue viability and wound care and the potential to spread into other areas. It's kind of why we try and do events like this, really, isn't it? To showcase what's happening across some areas to actually try and get that happening on a wider basis across the organisation. So thanks very much.
Thank you all.
Just note that while we're changing over the presentations to invite Barry up next to talk about Stroll and the use of Stroll as a digital therapeutic for neuro rehabilitation. There was just one question while Barry's getting set from John Scott online, and I think it was just after your presentation, Lisa, around do patients get too engrossed? And I suppose it applies across both. Therefore, they don't respond to instructions or questions. Or...
Yes, they do at times. So yeah, so we have to set some sort of boundaries and give some guidelines and things. And obviously, you know, when you try it out, there are some games where you need to actually physically move. And there's some games where obviously you relax and, you know, we need those specific relaxing ones, for example, for an LP or, you know, something where you've got to keep really still. So yes, they do get engrossed and, you know, kids, young people do love them. So yeah.
Thank you, Lisa. Thank you. John, I hope that's answered your question. And with that, I think I'm going to move on to introduce Barry Morgan Davis, who is NHS Morgan Jones. I think I've mixed you up with Rachel now. I do apologise.
We got married.
I'll let you introduce yourself, Barry, and over to your presentation. Thank you.
Hi, I'm Barry Morgan Jones, not Davies. With a name like that, yes, I am from Wales. I know I don't. Don't need to remember the reference. Stroll. So current challenges in neurorehabilitation. Right, rehabilitation services across country are under immense pressure. Most patients get, on average, between 1 to 2 sessions a week. That's falling far short of NICE recommended guidelines for rehabilitation. Does anyone know what is the NICE recommended level of rehabilitation for patients? No? It's 3 hours daily for 5 days. Now you can imagine trust being able to deliver that. That's a massive fix. And the reason that it's 3 hours, it's not kind of taken from there. It's a calculation to judge how quickly a patient can move through their rehabilitation journey and, you know, gain independence or maintain functionality. So what are those challenges? It's things like workforce shortages, so lack of therapists to actually deliver the actual care itself. Long waiting lists in terms of outpatient rehabilitation, high therapist workload. I know this being a clinician myself in my previous life. Therapists are at capacity already and they're asking to be over and deliver what they're currently able to provide. And a big thing as well is poor adherence to paper-based exercises. So generally therapists or either OTs or physios will give, you know, a sheet of exercises to patients, go back to your rehab unit, back to your bedside, I'll go home, do these exercises, and then I'll review in the next day or a week later, whatever, and do they adhere to rehabilitation. These all contribute to delayed recovery, longer stays in hospital, and an increased demand on social care. And also access is even more limited in rural and underserved areas. There's worse things about the health inequalities. So what's the solution? Stroll. So we provide it's augmented reality, not virtual reality, which I'll go in a bit detail about that. It's a method for delivering high dosage and high intensity rehabilitation. It enhances adherence. So in the rehab world, adherence is quite a big word, an important word for us as clinicians. That's the way that patient interacts with their rehab program actually does it when the therapist isn't looking. Optimize treatment outcomes, complete visibility. I'll explain that in the next slide. There's a handover from the therapist saying to the patient, right, go away, go and do your exercises, and then there's no visibility to does that patient actually do the exercises. Our solution is not just the headset, it's the software package that we provide. It allows therapists to have complete visibility in real time what they actually do when they're by themselves in the rehabilitation. And also, with our software package, it reduces the burden from an admin perspective for therapists. So it can be used anywhere. It's not confined to a rehab unit. It can be used in clinic. It can be used on a ward, so a patient's bedside. So, for example, the stroke setting. Our kit can be used day 0, day 1. So once that patient's deemed medically fit, if they're thrombolyzed in a stroke unit, for example, they can start using their kit straight away. There's no delay to their rehab journey. It can be used at home, so patients can be discharged early, put from a ward or a rehab setting into their own home, and they can do it in their own environment. And it's augmented reality, it's not virtual reality. In a clinical world, that's really important, I think, for anybody, for adults that can engage with something like to see and interact with it. It's in terms of a safety element. They can still see their own world in terms of the walls, see people, see furniture. And it's mobile as well. So VR tends to be quite seat-based activities, augmented. People can walk around their rehab unit, their house with a headset on. It's personalised. So generally, a therapist will give a sheet of exercises to a patient. It's quite structured. It's quite mundane. The way that our program works is that a therapist can bespoke a rehab program exactly for patient needs. It's fast and easy. It takes 90 seconds to power on. For patients, then just put the headset on and away they go. Multi-user, I think, with perhaps not VR, but with augmented reality, a therapist can wear a headset, the patient wear a headset, they enter the same world. And from a clinical perspective, the therapist can, especially with the patient that's at risk of falls, you get your hands on the patient. So it's really interactive from a therapy perspective. It's motivating and fun. So what we've done is we've turned the exercise on a sheet of paper that a physio or an OT would give a patient. So upper limb tasks, lower limb tasks, activities, and we just turn it into a fun sort of game-orientated rehab program. It's objective data. So with the software, when the patient wears a headset, the therapist will get that real-time data in terms of, are they actually doing the activities that are being prescribed? And then the therapist can then tailor their rehab program in real time. They don't have to bring the patient back into the clinic or back into the ward. They can do it in real time. So this is kind of the overlay of what our platform looks like. So you show the ring. So touch me over. So it's not just a headset. If you unplug it, there you go. Another one. That's it. Yeah, that's it.
The glamorous assistant role. Maybe not so glamorous.
Yeah. So this is the headset. It's quite intrusive. It's quite small. Our early design was a lot bigger than this. Our next design is going to be a lot smaller than this. It'll look more like a pair of Ray-Bans eventually. So as part of the package, you get patient wears a headset, therapist wears a headset, and then we also got here on the far left, you've got the dashboard. It's a web portal that the therapist can use instead of using their sort of medical records. They can sort of maintain their sort of patient record system via our dashboard, and that's how they bespoke the rehab program. It's not a set of exercises that they give to the patient. It's a set of rehab goals that they can tailor, make it easier, harder. So patient gets prescribed the headset. We've got assist, we've got rehab, and the assessment, the assist. It's called queuing. It's about a common sort of word in the neuro rehab world, especially for physios. We use queuing. You might be going to a physio gym where you see sort of red tape lines on the floor. They're not there to sort of cover cracks. They're there on purpose. That's to help patients like participation and things like sort of freezing their gait, sort of overcome sort of like that freeze and walk a lot easier. We've turned that into a virtual sort of augmented reality version of that, so the lines follow the patient. The rehab games, we have things like boxing, basketball, lots of games, jigsaw puzzles, where it's upper limb exercise, lower limb exercise, and we just turn it into a fun game. And then once the patient's been prescribed it and they start doing exercises, all of that activity gets lifted via the web portal and in front of the physio. So adherence is key for us. It's a big handover to patients, a big responsibility. Like we give them the program, now go and do it. We don't know as therapists if they are going to do it. With our headset and our platform, we'll know exactly A, they've turned the device on, so are they actually engaging in rehabilitation, and B, the performance of their rehab exercises, so we can make them easier if they're not, if they're struggling, or make them harder, and that's in real time. So they're not waiting for a week or 2 weeks for their next appointment. They can do that in real time. So the patient can remain in their own home, less travel for the patient, less admin time as well for the physio. But It's not about me, bang about how good we are. We rely heavily on science. We lean heavily onto science. So globally, we've had sort of 12 ongoing sort of peer reviews or clinical trials, and we've got 5 currently ongoing right now. In fact, we've got 1 actually in the trust ongoing. They've just finished their data collection. Dr. Rory O'Connor and Caroline Gill, they are in the process of doing their data analysis. So really looking forward to seeing what that data looks like. One of the studies that with our scientific partners in Amsterdam via VU University, so they did a 6-week trial with 24 patients where they were assessed for their functional ability before the glasses, and then at the end of 6 weeks they were reassessed. And the same trial or similar trial is happening right now with Dr. Rory O'Connor and Caroline Gill, and I think we're going to expect similar results. But in terms of key findings, we've noticed that it's safe. And this, from a rehab perspective, that's really key. That means 0 falls. Now, for those of you who've worked in rehabilitation, patients fall all the time. That's why they're in rehab, you know. And to do a trial for 6 weeks where we've had, patients ranging from the age of 51 to 82 have no falls, that's brilliant. That's to be able to say that. Adherence has gone up. So a big thing that, do patients do their rehabilitation when they're left to themselves? Not often they do. But our adherence was 104%. So that for us means that not only were patients doing their rehabilitation program, they were doing over and above what they were prescribed. And that's exactly therapists what we want to see patients do. It was well accepted. I think we scored, 8.8 from a qualitative perspective. So patients really liked the product. These figures here in the middle, so 15,000 minutes of rehab, 99,000 meters walked, 32,000 sit to stands, and 284,000 functional reaches. Now, I don't care how good a physio you got here, there's no way they're going to get their patients hit those numbers. Absolutely not. And that means a shorter stay in hospital. It means patient recover quicker. So these are good indications for us that it's working in terms of reducing length of stay. In terms of why choose Stroll, as mentioned earlier, so it reduces waiting list and optimizes workforce efficiencies, prevents falls, which means there's less likely patients to turn up to ED with a fall, and enhances financial sustainability and operational efficiency. I mentioned earlier, so Dr. Rory O'Connor, he's an advocate of Stroll. We've been working for the last 3 years. Here in the middle of some of our partners that we've got. In fact, it's an old slide. We've got more partners on boarded now. We've got quite a big presence in America. There's a version of me in America as well. And these are some of our partners. So I think one of the biggest there is Cleveland Clinic. I think they're the second biggest healthcare provider in America behind Mayo Clinic. They've actually invested £3 million. That's, in terms of how they like our product quite a lot. They did develop their version of augmented reality, but they've actually stopped production because ours is better. So they've invested their money into us. So that it's a great to them as a partner. That's it from me. Thanks for listening. Any questions?
Thank you very much, Barry. Thank you. So take any questions for Barry quickly, or if there's any online.
Have you done anything with children?
No. Oh, that's only from our glasses are a registered medical device. So 18, in terms of being a class 2 medically registered device, it's only for adults.
Thank you.
But in the future, we are a startup. We've been going for about 4 years now. We're just limited by the amount of hours in a day.
Yeah.
In terms of we can actually sort of build and to progress. In terms of peak repeats, yes, it is on our sort of roadmap, but not right now.
Good. Thank you.
And a question online from John: Do the glasses work with prescription glasses?
Good question. Yes, they do. Sorry, they don't work with glasses. However, I don't know if you can see. Can they see me?
Yes,
Yeah.
should be able to.
So with these glasses, all right, these glasses, just behind here, as part of the pack that we give to a trust, there's a big pack of prescription lenses, and then the therapist will just ask them what the prescription is, and it will pop them just in there, so they don't need to wear glasses. So no one disadvantage.
Thank you very much. Okay, thank you very much. I think we're running slightly behind, and this is the point where we move to look at future opportunities. And I'd like to just bring Alex Lancaster in straight away from Recreo VR, how they're using this in dementia care. Thank you. Thank you.
Hi, everybody. I'm quite fortunate that there's been some great people already that have highlighted the benefits of virtual reality for me, so that can save some time. But I think the main point for me to mention, to follow on from that, is that those impacts, that interest, they don't change with age. We just 3 weeks ago I used that with an individual who's 104 years old in a care home. Family were there in the room visiting. Again, a great experience. They all went to Paris. Again, actually, they all went together earlier in life. So what we have done is we have built a virtual reality app and experiences suitable for elderly adults and individuals living with dementia. For the first 2 years of the company's life, we primarily worked with adults in care homes, hospices, and charities, who were then fortunate enough to partner with the Alzheimer's Society, who took us onto their accelerator program, where we then co-designed, developed, evaluated our service with individuals living with dementia and their loved ones to build a service, a structure, a way of delivering virtual reality in a safe and meaningful way to really enrich the lives of individuals, whether they are in a care home or they are receiving care at home. Virtual reality just allows the opportunity for them to experience something new, re-experience something that's been meaningful in their past, and allows them, particularly when working with individuals with dementia, to recall memories that otherwise wouldn't be recalled, essentially. What we've built, it's really stripped back. You turn it on. It's gaze navigation based, so there's no controllers, there's no menus. You turn it on. You're in a 360, just a still image, and you're met with some images. If you look at an image, a video will then begin playing. And that video is what we have built and tailored around, let's say, whether it is a narrated tour of Paris, whether it's inside the enclosures at Edinburgh Zoo. On the slides, you can see that. I won't turn it around because you can see me getting chased by a penguin trying to record it. We partner with the National Trust, so we have virtual tours of National Trust properties, which again, obviously, things like that have been had a massive impact on individuals' lives. So again, to be able to revisit places like that and to be able to talk about it with either other residents, other individuals in this care setting, the carer, or it could be a loved one as well. So the headset itself, there's no wires, like I said, there's no controllers. It's really lightweight. The battery is on the back, so it's counterweighted. I've got one here as well, and obviously we're going to be showing it, I think, after the presentation. So do come and try it, and you can see. And I say we build and record most of the videos for it ourselves. So we've created a very strict structure on how we do that. So there's no movement, for example. As soon as you have movement, we some other entries that will maybe have a walk along the beach where the camera's moving. If your body's not experiencing that movement, that disconnect is what then can cause the nausea. So what we've built, again, strict structure, all stationary cameras at sitting eye level height, because again, sitting down, as you mentioned, rule 1. So and again, like I say, used in a way that is both safe, meaningful, and importantly, easy to use. We understand in care settings, when you're introducing technology like this, if it requires any additional steps to set up to begin engaging with the service user, it can often just be put aside. You haven't got the time. you haven't got the kind of mental space, and you're maybe a bit overworked. We don't want to have to then try and integrate something new that's a hassle. I can yap on for it. What I think the best thing I'll probably do is on the next slide, there's a video of a chap. I'll just introduce him. He's an individual with dementia at a care home that we work with, and his father was a pilot in the war. So we linked up with a professor down south who'd actually recorded some 360 video in a Spitfire in flight. So again, it kind of goes a little bit against the rules that I've just explained. So this was a bespoke session that we'd done, because we build an app for the organisation that we work with. It's branded, get your own private content server. So say if somebody comes in that is I don't know, would like to visit Berlin, for example, you just let us know, and then if we have it, we'll either source it and then we'll put that trip on them. So it really allows a person-centered and meaningful experiences on there, whilst also our wider library, which again you'll see a little bit of section. Is it? Can I control this? Yeah, lovely. Okay, cool. So here he is. This is just going to open YouTube or so?
Yeah.
Clicking.
I think it's flashing at the bottom.
Is it open? Is it that one? Yeah. Ah, yeah, I see it. There he is. Right, we've got the sound. Yeah, so you got a glimpse there of that.
Can you imagine anything just like
It's incredible, isn't it?
I know. Is he coming into land?
I think they are coming into land.
Let's see if he is. Oh, levels out. Oh, boy. Oh. Oh. Wow. Magnificent. Out of this world. Out of this world.
Do you enjoy it?
You can imagine things being, really, really beyond belief.
Oh,
I was so happy with it. So I couldn't imagine anything could be that good. It was so good.
Oh, I'm so glad you enjoyed it.
It's just a good.
Oh, thank you.
Honestly, those kind of reactions we see often. So that we went on site for that. The care team there, they have it. They use it with him. He's used it a couple of times himself, so he actually navigates and he chooses the experiences himself as well, which again gives him a choice of the library. I think if it's on there, I may as well just quickly pop on here instead of using the other slides. So this is our YouTube account, and it kind of gives an example of the kind of things that we have on here. When it's Christmas, we'll make sure we've recorded it. National Trust properties that are all decorated up and kind of sharing resource packs as well. Because the thing that really makes a difference, we find. So while it is fun to everyone, we'll do this one. While it is important that the experiences and videos that we have on there are meaningful, it's really about communicating with the individual. But while they're in it, and after, I'll just put this on there. on mute while so I think you can move around and see. There's a sloth here. This is Edinburgh Zoo. This one. Just a couple of clips here. And it's so what we have. So again, these are some more specific examples. But say a lot of our library is built around say a UK harbour town or just cities from around the world, which allow people to, say if you're working with an individual and you're working on some reminiscence therapy with somebody, usually what we'll be doing, we'll be looking at photos, videos from their life. Those instances are very specific occasions in which they've already had an emotional response to, and it's about bringing that emotion back. What being immersed in an environment like this does, it allows them to bring forth their own memories. It's not dictated by what's on there. If they're at it's nice being up north. If they're in Whitby, for example, right, we can show somebody down in Plymouth, Whitby, and it will get them talking about their holidays, the times that they were at the beach with their families, and instantly you've then got a conversation starter. So, oh, who was you there with? Tell me about it. What did you like? And in instances where maybe, so it's a bit different in care homes where the person delivering the care can form a relationship with an individual over a few years, and even in using this, they are still finding out new things about people as they're given the opportunity to share more about their life, which then builds more connection, not just between the carer or the loved one, but like I said, between residents and service users as well. If two people are going on a trip to Seville together in a headset, and they've both been to Spain, maybe different places, they're going to start talking about it, and that's really what I did.
Sorry, just one more.
Okay, yeah, sorry. So yeah, I'm going to go back to the slide then, because I just the Recreate, there we go, and I'll jump to here. So one of the important things that we did whilst working with Alzheimer's Society is we did run an evaluation of our services. To preface this, we worked with 101 individuals in a range of different settings, care homes and community-based settings. We did ask individuals if they would like to try new reminiscence technology. That was the cohort of 101. And then when faced with a virtual reality headset, which again, can imagine can be quite daunting. So again, what we have built is communication and training on how to deliver it. 97% found the headset comfortable. It's actually 90%, the one I've covered up there. 97% when faced with the headset did choose to try it. Like I say, age really, the interest in adventure and trying new things really doesn't diminish with age. It really doesn't. 97% found it comfortable, 90% enjoyed their VR experience, and 86% enjoyed it and wanted to use it again in the future. And those kinds of impacts that we see across a range of services, really increasing the well-being and the experiences that people having when they're in these care settings. I'll end it there. Thank you.
Thank you very much, Charlotte.
Cheers.
Thank you. Just a very quick, any questions for Alex, Mary?
Have you got any data on falls prevention? Has it prevented falls?
We haven't looked to collect that. No, we want it's a really stripped back. So there's no logins, there's no data collection to it. You turn it on, you've got your videos, you select it, and that's it. Any collection can be done outside, but no, with that, that's not solved for what things we've been.
Okay, thanks very much.
Cheers.
Thank you. And like Alex says, he's got the opportunity to try it out later on for those in person. So next, and thank you for waiting patiently, we have Tom. Tom, can you hear me there? Yes, you can.
Yeah, I can hear you.
So Tom is just going to present on some of the ways that they're using virtual reality and their future direction in Chelsea and Westminster hospitals. So Tom is a digital innovation fellow there. So I'm going to hand over to you, Tom, and thank you.
Thank you. Can you all hear me okay?
We can.
Perfect. Just while I'll get my slides up. Yeah, thank you. I'll start with some huge thank yous, actually. Thank you, Richard, for inviting us to speak. And to the previous speakers as well. It's been really inspiring listening to you. My colleague to my left, who I'll introduce in a minute, we've both been sort of frantically taking notes. I'm reticent to follow those, to be honest, because I don't. My role is once removed from the actual clinical delivery. So I think where you've all been able to tell some really powerful stories about patient experience, I'm going to give a bit more of a helicopter view of what we're doing at Chelsea and Westminster. So I work in a team called CW Innovation. We span the charity and the trust. So I'm technically employed by the charity, but I'm embedded within the trust, and that's where I do all my work. To my left is Aglaya. Do you want to say a quick hello?
Hello, nice to meet you all, and thank you for inviting us. As Tom said, we kept notes, and we might reach out to some of you individually just to get some more details and see how we can collaborate.
Yeah.
Thank you.
So I'll talk a bit more about Aglaya's role at the end of the presentation. So I think on the agenda you were promised something about the early pregnancy unit, so I will mention that case study as well. But I think we're on very similar trajectories at our trusts from hearing the presentations. There's some things that we're doing that are very similar, other things it seems like you guys have raced ahead, and we'd love to learn more about what you're doing. And there might be a couple of areas where it seems we've sort of moved in that perhaps you haven't yet. So it'd be great to do some of that sharing and learning. So we've looked at a number of technologies. Barry mentioned this, that of course there's more to VR than just VR. So there's obviously augmented reality, which the Stroll technology utilizes, which is overlaying virtual elements on the real world. So on the bottom left corner there, you can see a project we did using augmented reality to train staff to recognize and manage signs of domestic abuse. This is an area that it's obviously really important to be up to speed on training and how to spot these things, but you don't see that very often. So augmented reality offers great opportunities to do that sort of thing, and to have a higher frequency and greater exposure to it, more so than you can get in real life. The other one that touches more on augmented reality is top left. We've been using avatars that appear on your phone when you sort of hold it up to an area, and this is being used to help children or help inform children about surgical pathways, prepare them for theatres visits. We've actually adapted that to use it in the ICU as well with adults, so helping families of patients understand what's happening to their loved ones. And we've also been applying that to the CAM setting, where there's equally lots of anxiety amongst children about moving into a mental health pathway, and we can use that technology to help reduce some of that fear and anxiety, and inform them a bit more. Then obviously we've got the more traditional virtual reality use cases, which you'll be familiar with. So we've also been exploring lots of different opportunities for using virtual reality for pain management and distraction. We've also been using it for staff training. So there was a project I was quite heavily involved with, using it for equality and diversity training. So this was something completely unique to VR as far as I'm aware. What we did was we developed a scenario where you could be embodied, you could essentially occupy the body of a black woman and experience microaggressions. You'd go through a meeting and you'd be able to experience that meeting from different perspectives. So, it's something that you can't achieve even with kind of role play and theatre groups. It's something that you can only do through this technology. So, as a sort of broader overview of the things we're looking at, these are the sort of general headings, I suppose, the areas where we're seeing opportunity. I think I'm adding one. I'm adding a column after today. I'll be going and talking to our learning disabilities team as well. So thank you, Rachel, for presenting so well on what you've been doing. We'd love to get in touch afterwards. But as you can see, we've majored on a few areas. So we've done quite a lot in the area of pain and distraction. As I say, I'll present a particular case study on that in a minute. Staff education, that equality and diversity training was an early project, and it's inspired lots of others. Something that I don't, well, perhaps this does relate to the Recreo VR experience as well. I think there's a lot to be said for using this as entertainment and not to be afraid to present it in that way. I think that has a lot of value in and of itself for patients and staff. We've had a recent inquiry from a palliative care team wanting to use VR for a patient who's bedbound, who, you know, realistically they're not going to be leaving hospital at all. So what can we do with VR to help you know, broaden their horizons, give them an experience, a bit of joy in their day-to-day that otherwise they're not going to be able to access. And it was really interesting listening to Barry. We've been emailing Barry, so it's nice to put a face to the name. We've looked at MSK rehab in the past. We've had projects going. They've kind of started and not quite persisted, but it's definitely an area of opportunity that we want to continue exploring. I thought it might be interesting to map all of that to a timeline as well, because this has been going on for a long time. Again, I'm sure it's similar over there. We've kind of had fits and starts. I think as the technology has gotten better, the potential that we've all kind of seen and imagined for a long time is now at a stage where it's being realised. And although the growth in projects isn't quite exponential, you know, every year we're getting more and more applications to the charity for VR headsets. You know, different services are coming forward saying that they've thought of a really good use for it, and I think I can only imagine this trend continuing. What I would say as well, the 2021 was a sort of inflection point for us, where I think more by luck than any sort of design. We had several really interesting VR projects come through the charity grants in that year. So one of those was the equality and diversity training. There was another using augmented reality for theatres training of medics. And there was the early pregnancy unit case study, which I'm going to present in a sec. And I would say that those have been really core to inspiring a lot of the other projects that have gone on, because we were able to demonstrate really good patient outcomes, really good business cases as well. Like we've been able to make the finances stack up. And again, that's something that Rachel touched on. You know, we also want to make this core business, but we don't want this to be a kind of cottage industry, like happening in pockets here and there. I think we'd like to make this something that's just part of the norm and how things are done, especially where there are these kind of no-brainer cases when it comes to the clinical and the business case. So I'm nervous about presenting someone else's work, but I'm going to attempt to present the case study from the early pregnancy unit. If you are interested in learning more about this, I can connect people with our project leads on this. Natalie Noons was our consultant gynecologist, and Lauren Trepty is a research midwife. So this all was their brainchild. So the basic setting or how it got started was they applied to the charity for funding in 2021, as I said. There were delays due to COVID, but I think also in a weird way, COVID was in some ways the making of this project, which I'll explain in a sec. staff were sort of trained up, as you heard from others, so I won't go into the details of how we did that. We designed an evaluation around this, which really has helped us focus minds around the rest of the trust on the financial and business case for these sorts of projects. And also, of course, the patient feedback has been critical. So I should say, sorry, the procedure that this was being used in the early pregnancy unit, they receive patients who have unfortunately miscarried, but the miscarriage hasn't passed naturally, or it's taking a long time, or they'd like it to happen sooner. So they undergo manual evacuation. It's not a pleasant procedure. A lot of people before COVID were opting to have it done under general anaesthetic, but those that didn't, this was the view that they had. You know, not particularly nice. Necessary, obviously it's a clinical area, can't be helped, but Natalie and Lauren wanted to do something about that. So we've used VR. I'm not going to play the video because I don't want to I don't know where this link will take me, but we use a headset called Smiley Scope in a similar way to the other projects that presented. You know, it offers different sorts of distraction scenes, nature scenes, games, that sort of thing. Oh no, it's trying to play. The reason this kind of came to the fore during COVID was, so yes, the project was delayed by COVID, but what Natalie and Lauren were finding was that more and more women were requesting to have these procedures done under local anaesthetic, because it meant a shorter stay in hospital. So, you know, people worried about COVID infection and hospitals and all that. They were just wanting to get in and out. So there was it was one of those things where there was a moment in time, I suppose, where just as this demand was increasing massively, there was also this technology that helped facilitate that and make it a more pleasant experience than it otherwise would have been. So as you can see, there was a huge uptake. 60% of people that were offered it took it. There were obviously the other 40% still opted to either have it without or to have it under GA. Everyone that used it said that they would recommend it and that they would use it again. Average pain scores came down. What's not on this slide, because it wasn't an outcome that we set out to measure, so we didn't sort of do a good job of capturing this. But anecdotally, we had a massive modal shift from these procedures being done under general anaesthetic to local anaesthetic, and where that made a lot of other people sit up around the trust is the huge cost savings that comes with. So, you know, these headsets, doesn't matter which company you're going to, in the grand scheme of things, they're pretty cheap. So if you can save thousands of pounds on a procedure, what was it? Rachel got the catheter change down from £3,000 to £400. You know, there's your business case for a year for a headset, isn't it? And that's just one patient. We found exactly the same sort of thing in this setting, and we're finding it in pretty much every setting that we look at. You know, we're doing projects in urology now. We've replicated this in sexual health for IUD changes. I think there are huge operational improvements to be had from this, and I think that's where the business case is to be made. I don't think we should be presenting this as a cost implication. I think these are all huge potential savings. I was going to do a second case study, but I'm conscious of time. Richard, shall I just skip along and do a wrap up?
If that's okay, Tom, yes.
Yeah,
thank you
I will.
that.
Yeah, I'm going to skip ahead. What I will say, sorry, I'll just dwell on one thing. This was the Equality and Diversity Project, and one of the most interesting findings we had from this, I've not even got it on the slide. We asked people when they did the Equality and Diversity training, we asked them about 6 weeks later, how did they remember the training? Did they remember it as something they saw or something they did? And it was overwhelmingly recalled as an experience. So it wasn't like they were watching something play out on a TV. They remembered it as something that they did. And it had, I think that's one of the reasons that we saw really great outcomes in terms of behaviour change with this as well. So I think that's another massive advantage of VR. The fact that it's an experience, not something that you just sort of do, like, you know, mandatory training on a screen. So our next steps, I think, are very much similar to what I've been hearing from you guys in Leeds. We've gone wide at the moment, or up till now, we've gone pretty wide with where we use VR. We've been pretty open about what projects we fund from the charity. We're essentially curious to see where this potentially can work. So we've had a pretty low threshold to approve these things. I think there's still something to be said for continuing that, but I think what we need to do is balance that with a need now to at some point say, look, we've done, you know, particularly on the pain and distraction side of things, we've done this in enough settings that I think we can confidently say this is a benefit. It's going to save time. It might help avoid general anaesthetic. It's probably going to save money. You know, we need to make that case. But the big part of kind of spreading further is that we want to spread it as more as business as usual and under the Trust core budget and funding. We think the business cases are robust enough that that's justified at this point. To do that, we do need leadership. So I think the people that have done this up to now are similar to the people in the room there. They're people that are passionate, that have been forward thinking and spotted an opportunity. And I think we need to spotlight those people more systematically, get them involved in planning our sort of strategy going forward. And as I touched on funding, I think we need to shift this away from being a sort of series of one-offs with charity funding and more into trust budgets. Having said that, I think so things that we're hoping our new innovation associate in VR will do is kind of help lead on all of that. So we sort of took a different view to this at the charity a little while ago. We funded lots of these projects and we're happy to keep funding them, and we probably will do a funding call like you guys in the near future. But we also thought, how can we kind of shift the dial on this? So Aglaya has been brought in essentially to focus exclusively on VR. Again, it was interesting to hear Lisa mention a VR play specialist. I think that's the way to go. I think we need champions at every level in the trust, within our divisions and within our clinical specialties. So we're really hoping that Aglaya, you haven't even started yet, but she starts in a couple of weeks.
Can't wait.
We're hoping that she can help us shift the dial on those three objectives for the future. So I think that's it. I'll wrap up there. Thank you very much. And let me say again, thank you so much for having us, Richard. And I'd love to follow up with the other speakers and sort of continue this cross-pollination, I suppose, this learning from each other.
That's fantastic. Thank you very much, Tom. I'm just going to invite everyone for a quick round of applause. It was a fantastic presentation, actually stimulated a lot of new potential opportunities, and actually just getting the insight of the growth that you've achieved in use cases at Chelsea and Westminster is fantastic, and that need of moving things to business as usual. I'm wondering if there's an opportunity for us to continue sharing like business cases that perhaps you've developed in Chelsea and Westminster that perhaps we could support moving the dial over here in some of that as well. So absolutely fantastic, and a good shout out, I think, to the Insights programme that brought us together very much initially. We're both fellow sites on that national NHS England funded programme trying to stimulate the adoption of new innovations across the NHS. So thank you very much, Tom, and thank you. Great to meet you two in role there as well. So thank you.
Thanks all.
Thank you.
Okay. And okay, so I've done I think I say this very often, done an awful job at keeping to time. Thank you, Charlotte, for your patience for sticking with us. People are holding there, so I'm going to move straight over to you, Charlotte, to introduce the funding call around this.
My presentation's quite short. Everyone will be very relieved about that. Mine is that one. Yeah, the purple one. That's me. I nearly wore my work t-shirt today and thought it would be just too much purple, but purple is our main brand colour, so a little bit of purple. So, hi, my name is Charlotte and I'm grants manager at Leeds Hospitals Charity. I'm going to give a little bit of an update on activity that we've done in the 24-25 financial year and an update on our funding opportunities for 25-26. For those of you who don't know who we are, this is our mission statement for Leeds Hospitals Charity, and we exist to support NHS staff across all of the Trust's sites, helping them to deliver first-class care to patients and families. So a bit of an overview from 24-25. So we approved 232 applications, totaling £3.29 million worth of funding. And those applications have the potential to directly impact 1.46 million patients, families and staff at LTHT. 40% of applications were from new applicants, which is one of the things that we were aiming for with our grants programme last year. So fantastic to see so many new applicants. There was a 73% success rate. So of everybody that applied to us, 73% of applications were successful. For those that complete our monitoring and evaluation forms, the satisfaction rate of the experience of having funding from us and the application process is 8.5 out of 10. So we're really chuffed about that. And the big stat on the right-hand side, since the launch of our 5-year strategy in 2021, we have awarded £25.5 million worth in grant funding. So this is just a quick example of a project that we funded in 24-25. We awarded £13,908 via a specific donation from a donor who was interested in supporting immersive activities for patients on the older adult wards. So this is the Happiness Programme. It's an interactive projector that can project onto any surface, such as a table or a bed. Then you can use your hands, arms, feet to interact with games that are projected. And there is a video. I really hope it works, but if it doesn't, we can skip past it. So this is to hear from the company Social Ability, who developed the Happiness Programme. Ooh. No.
Might be able to try.
It was embedded, but it looks like it's not working. Anyway, so if we had seen the video, you would see some examples of people playing like air hockey on a table using the projected screen, and also with a paintbrush, like colouring in a picture. So moving on to our funding opportunities for 25-26. So staff working at LTHT can apply now for our patient experience enhancing the healing environment funding opportunity. Applications are invited between £75,000 and £5,000 and £10,001 and £50,000. And we are looking for applications to take a holistic view of patient care, creating creative and therapeutic spaces and healing environments, which could include VR. That is one of the things that we that you're eligible to apply for, but could include a whole range of different interventions, enhancements to the physical environment, other projects, etc., that would align with that. Stage 1 application is a video or a presentation with a voiceover, and the deadline to submit that is the 9th of June. On our website, we have full guidance. You can also book a one-to-one with me or one of my colleagues on the grants team to discuss your application. And this is what's coming for the rest of the year. So we will have a research opportunity around improving outcomes in mental health for children and young people, launching June, July time. Innovation in healthcare opening in September, and an opportunity around health inequalities launching October time. And if you'd like to find out more, we do have some postcards, I believe, that we can hand out to Trust staff, yes, that were shipped over because I forgot to bring them. You can scan the QR code here for Trust staff to sign up to our newsletter, email address there, and our website too. And that's me. Kept it very short and sweet.
Fantastic.
Right.
Thank you very much, Charlotte. Thank you. Were you good with any questions? for Charlotte?
It's just like, yeah, just go and sit back down again. Does anybody have any questions?
Any questions from anyone online? No? Okay. So I think it just saves me to say, and I appreciate we've run slightly over time tonight. Of course, for those in person, you now have the opportunity to actually experience the kit, which is, please do take us up on that. I think that's been a fantastic session today. It's stimulated a lot of ideas for me. I'm sure it has for others, and it's nice where the ideas could meet a potential opportunity. And this is, I think, not just about the funding call, but about some of what we've heard, particularly those new use cases from Alex at Recro VR, and Barry from Stroll, and also what they're doing at Chelsea and Westminster. I think we've got a lot to learn here from not trying to reinvent the wheel and do things ourselves, but what are others doing that we can actually lift and shift and try and approach in our own organisation. So I'm just going to say a big thank you to everyone online, and for everyone who's attended online today. Big thank you to all of our speakers and everyone who's attended in person. And I think that's probably time to close and move on to the chance of testing things out. So thank you very much, everyone. Thank you.